Okay. Hey, great. Okay,
Yep.
cool. Thank you for that, Udunna. All right. Just to go ahead here. Yes. So, Dr. And now things are bringing. Dr. Udunna, Dr. Anazodo completed her doctoral training in medical biophysics at Western University and was a MITAX Accelerated Fellow at the Lawson Health Research Institute. She leads the multimodal imaging of neurodegenerative diseases, MIND, lab at the Montreal Neurological Institute, where her group develops PET and MRI techniques for quantitative neuroimaging. I think with that, I will just hand over to her so that she can just kick us off. And yeah, I will just say, sorry, just for context, that there might be a cutoff where you have to rejoin the Zoom, but Dr. Nozodo will lead us through this. So thank you.
Great. Thank you for that amazing introduction. I'm super happy to be here. Good morning from Montreal. I'm going to be talking about bridging the AI and medical imaging divide in Africa. It's going to be a medical imaging talk. So for those of you that are not familiar with medical imaging, we may not have time to dive deep into it, but you might see some spotlight of it. And if you have any questions later on, you can always reach out to me by email. I'll be happy to talk about that. So I'm going to be talking about work done by my lab in McGill University in Montreal, as well as the extension of my lab in Lagos, which is the Medical Artificial Intelligence Lab in Lagos, Nigeria. And that's the only lab, to my knowledge, that has an AI lab, an AI research center within a private radiology practice in Nigeria. So that actually allows us to do this bench to bedside work. And I'm going to show you a lot of work we're doing to bridge that AI gap. I don't know if you've seen this. This was posted on LinkedIn and Twitter. It was all on social media back early this summer, where it talks about this global AI divide. And this is highlighting where the data centers are located around the world. So this is where all of those AWS, Google data centers, or any other data centers that are typically where we, if we were to use cloud computing, are located. And you can see that, luckily for those of you in South Africa, within Africa, they're all within Cape Town or the Cape area. And so, this is obviously typical African story. Africa is always left in the dark, for lack of a better word. But we've known this. My group and I have known this. We did a tutorial back in 2022 in radiology area where we talked about the need and the potential aim of making sure that artificial intelligence, when it comes to healthcare and especially in radiology, and I'll tell you why it's important in radiology, that we need to start thinking about this gap and how to close this gap because of the power of AI in being able to really address some of the healthcare burdens that we tend to have, especially the ones that are non-communicable disease, where medical imaging is very critical. Now, we've seen over the past few years that AI, and in this case, I'm talking about machine learning and deep learning, when it comes into medical imaging, we now have some of these tools coming into clinic. So here are some examples of some of these tools that have been 510. So these are FDA cleared. Some of them have been C marked. So these are now actually in clinic and being used every day. The reason I picked this too is because I'm talking about brain tumor. Brain tumor is a very, very rare disease. So even within these rare cases, people are making many different types of tools that will aid radiologists, that will aid medical imaging, that will aid oncologists in being able to diagnose, classify, and also do management of the disease. So if this is happening in a very rare case, you can imagine this is happening in very common cases like TB or with X-ray, which is one of the very few applications of AI in radiology. And even with the hardware itself, so how we scan, how we acquire images. So this is an example from Siemens Healthcare, where they have now AI embedded within how they reconstruct the images. So even before we get the images out, AI is now being used to essentially augment what we're seeing with the medical imaging. So AI is here to stay. And the question is, how is that going to impact us in Africa? And then how can we actually start to get ready and bridge that gap? Now, when you look at within medical or healthcare, and you look at where is AI being mostly used, mostly developed, where is the market share, where is the footprint, it's radiology. Most of all the development since, if you're going back almost 20 years ago, has always been in radiology. So radiology takes about 70% of all AI applications in healthcare is in radiology. Now, if we go within, where are these AI applications being used, or where are they? Obviously, if you develop it there, you might most likely using it there. You see that this is mostly in the West, and obviously the US takes the cake. But within Africa, there's none. There's nothing happening within Africa. But the most important thing I wanted to take home, and something I wanted to stress here, is that most of these AI applications that are making its way to clinic, a lot of them actually haven't gone through the typical pathway of drug, because that's kind of what we've done. Um, um, well, I say drug discovery pathway to clinic, which is through clinical trials. And this is something that people have now been talking about, and that's very important to pay attention to that. The other thing I wanted to stress out here is that most of these devices, actually, many of them have not been validated on African population. So we have medical devices that have been developed in the West, by making their way into how we scan and how we collect our images on the hardware, making their way into software that our radiologists and oncologists and maybe other neurologists, people around the healthcare center are using, but they have not been validated on our population. And last thing I wanted to mention before we start to figure out how to bridge this gap is that most of these AI medical devices are obviously developed by public companies, but quite a few of them are recalled after they've been approved. And most of the recall issue is, most of them comes down to generalizability. So if the West is having issues with generalizability, we can imagine what that would happen when they start to apply it to us, or when they start to develop it for us without obviously understanding our disease patterns, how our healthcare system is. So we're going to see that most of this healthcare device may be recalled, especially if we're thinking about it within our porous medical device ecosystem that have across Africa, which is quite, in some cases, non-existent. So I want us to put that all into context as we sort of start to think about ways of bridging this AI divide gap, especially when it comes to medical imaging. Now, I'm going to use brain tumor to highlight this because, again, this is a very rare disease. And if we're making all this effort in this one domain, you can imagine the amount of effort that's happening in many other domains within radiology that impacts many different healthcare disciplines or healthcare settings. And the reason I'm using medical brain tumor is because there's been quite a lot of effort done within brain tumor. Most of the AI-enabled, machine learning-enabled, deep learning-enabled medical imaging solutions that are coming into neuro-oncology, into brain tumor, are basically happening because, almost 15 years ago, 10 years ago, more or less, there was a data set that was put together. This data set had multiple different MRI parameters. And they also had expert neuroradiologists annotate, so they were able to sort of go in and figure out the tumor subtypes. This data set was made publicly available. This is the Brain Tumor Segmentation Challenge data sets. And from these, there have been lots and lots of groups, lots of papers that have been published, essentially trying to figure out the best way to automatically segment these brain tumors, classify them, characterize them. And this systematic review, of more so like a meta-analysis, is actually a great paper if you want to just kind of get a sense of how some of these data sets are benchmarked, or how are used to benchmark methods. And this essentially sort of gave us a window into how well some of these deep learning methods and machine learning methods actually perform it against, say, for example, a well-trained expert neuroradiologist. And the long short of it is that back in 2022, we've started to see that these methods have really high performance compared to a clinician, very close performance to a clinician, I should say. And more so in some of these very hard cases where it's sometimes very difficult, especially when we're working with African images from African settings that tend to be quite more noisier. These machine learning methods are essentially performing quite well. But the question is, when it comes to applying it to the type of imaging data sets that come from African populations, how do these methods perform? So my student, when he was a student in my lab, he's on a UBC, Dong Zhang, essentially looked at some of these top performing deep learning methods that have been really trained well on global north data sets, or data sets that exist at the time, and essentially found that most of them don't perform very well when you apply them to the type of imaging that we get from African settings. And when you now take those imaging from African settings and you include them in the training, your models tend to perform a lot better. And I don't think that should be news to anybody, because if you don't put the problem you're trying to solve within your AI model, you're not modeling the problem, so you're not going to be able to solve it. That shouldn't come as a shocker. But people would say an image is, an MRI is an MRI. Why does it have to be performing a lot worse than images from the north, global north? And the reason is this. Now, the images from the global north are typically high quality, what I call plenty shot, because they have high resolution. So the slice thickness, so brain imaging or imaging in general tend to be, especially when you're talking about advanced imaging like MRI or CT, computer tomography, or even post-emission tomography. These tend to be, the word tomography, they tend to be three-dimensional images. And a lot of those three-dimensional images, the reason why we do that is because we want to be able to cut through, like sort of pan through our area of interest, in this case, the brain. And so we have this slice, we sometimes can re-slice them, but it also has to do with how we acquire the images. And so the images tend to be higher resolution. They come from higher field in terms of MRI, higher field scanners, or even any modality. They tend to be much more advanced imaging technology that have been used in the global north. And they tend to be multiple different parameters. Like you can see, this is the same person's brain, but we've acquired in multiple different parameters that give you contrast so that you can actually start to see the tumor, same tumor, showing up in different types of contrast, which is why even a radiologist sitting down looking at it can be able to eyeball and with the eyes see the contrast difference and be able to read the images just virtually. So that's rich information, which machine learning or computers can do even better. And they have thousands and thousands of cases. Now, when you come down to sub-Saharan Africa, the technology of the imaging devices tends to be much lower quality, oftentimes because we just can't power them well. And so we have started off the bat with lower resolution images. Sometimes they're not three-dimensional acquired. They're two-dimensional thick slices that are reconstructed into three-dimensional imaging. And so you can see here, even on the coronal and sagittal plane, that there's a huge difference between the resolution of your imaging. We also have sometimes not able to do this rich, multiple different contrast imaging. You can see there's some contrast I'm missing. And obviously, we have few cases. Imaging is expensive. Patients show up late. Patients show up with advanced complicated disease. Patients show up with multiple comorbidities. They have HIV plus brain tumor, for example. So we have very complex few cases. So when you take this data set and you try to apply it to these type of models that are built on this data set, they will fail. And so we have to start to include these type of imaging into our machine learning models so we can start to bridge the divide where AI solutions can actually start to make changes in healthcare settings. Now, what are the key barriers that are actually preventing us in implementing, so taking what's been done and just say, let's just implement it, or even trying to build our own methods or augment what's been done, or try to do our own, like I said. One of it is, you have to start with data. Data is not there, you're not essentially doing much, and I've already talked about that. So a lot of the technology we have in sub-Saharan Africa, like I said, are what we call lower, in terms of MRI, low field. For example, some of the modalities don't even exist in Africa in terms of medical imaging. And when they do, most of them, especially in radiology, because it's a very expensive enterprise, are mostly in private practices that have no connection to academic center. So they're not a place where you can actually come in and say, okay, let's just do research. They have a business model or a business outlook. So you're trying to do this in a private practice. And they often scam with suboptimal protocols for so many reasons. And one of the main reasons is because the devices are not bought directly from the OEMs, from the original equipment manufacturers. You come in through a middleman that oftentimes doesn't know how the device works to actually train people on how to use the device. You have suboptimal protocols. Suboptimal protocols gives you suboptimal imaging. Another biggest barrier is trained experts. I'm going to use brain tumor again to illustrate what I mean by this. Now, if you recall when I was showing you that, let's just go back here. These models, they didn't come out of thin air. It took a lot of people just to be able to enable an AI method, a deep learning method, machine learning method to do tumor segmentation. You obviously have to have people that could do the scans, that could protocol and make sure that the actual images that you have acquired are for brain tumor, for this specific brain tumor, for this specific evolution of the tumor. So you have to have a radiologist, an oncologist, even a surgeon or pathologist. That people that tend to order this imaging, that they're well trained and they know exactly what they're doing and what they're ordering, so they could actually give you ground truth information to come out of that, including even annotating the images. You have to obviously have trained techs that could scan, physicists, even the informatics people, because if you don't have the data archived, there's no data to start off with. And obviously, you have to train the computer scientists, the physicists, to actually build models that are well informed. Most of these don't exist in sub-Saharan Africa. There's very few radiologists in many countries, in most countries actually. In terms of comparing the number of radiologists, oncologists, or surgeons, or even pathologists to any other part of the world, Africa always tends to come out the bottom in terms of the number of radiologists per that population or pathologist. So when they exist, they're really overwhelmed, and the communities are underserved. So we have to train all of these people just to do something as, like I say, as now almost becoming trivial as this. And also one key important thing is collaborative networks, because with medical imaging and data science or AI, not one institution can do it well. Because one, you want the models to generalize. If not for anything else, even if you're the king of data, you want your model to generalize. That's one. Second, you want to have access to multiple different imaging, because imaging is expensive no matter where you are, right? So the larger the population of images you have, the I'm not sure what's going on.
Priscilla, can you mute, please?
No.
Elaine, can you mute?
No. That's fine. Yeah. Hello. Good, thanks. How are you? Maluleke.
Okay, sorry. Udunna, you can unmute. Yeah, sorry about that.
Okay, thank you very much. And I'm going to have to just keep going because we have 6 minutes to switch over. And so you have to have multiple different institutions, because one thing, imaging is expensive. So oftentimes, and I gave you the example of the brain tumor segmentation data set that really kicked off development of AI models in brain tumor applications. This original data set came from multiple different institutions, mostly from the West, little institution in Egypt, but essentially, most of them came from the West. So we need those collaborative networks to develop the model, share the data, and also validate the model. So that's how we get towards really generalizable and robust models. Now, how do we close this gap in Africa? So we got funded back in 2022. This is the Lacuna Fund, which kicked off everything I'm going to discuss right now. And that fund is extremely important because essentially, from the name, it's called Lacuna. It was essentially set up to promote, allow, support, strengthen the collection of data sets. In this case, we apply to the healthcare fund or the healthcare program, so healthcare data sets, and make that data set publicly available so people can actually start to use African data sets to build models that include us. When we got that grant, we said, well, there's a lot of barriers that we need to overcome in the medical imaging space for us to even share data. And a lot of those barriers cut across infrastructure, personnel, and policy. And so these barriers are, and I'm not going to be able to go through all of this, but this includes what I just mentioned, the fact that our scanners or the way we scan are typically of lower quality. We have to figure out how to overcome that. The lack of data storage, you have to be able to store this imaging in a picture archiving system, which are very common in hospital settings, actually central and part of hospital settings in the West. But PAC systems or picture archiving systems don't exist in most African, especially sub-Saharan African imaging or medical imaging centers. Obviously, we have very expensive, unreliable network connectivity or even the hardware itself. Personnel, I've talked about all this personnel that I have to train them on how to acquire images very well, train them on how to annotate images very well, train them on how to do imaging informatics, or even how to now take that biomedical imaging and build really highly informed models. And policy. Now, like I mentioned earlier, a lot of these medical imaging devices are within the private sector. We have to figure out how to get them to understand what research is, be able to even want to do research. We have to figure out how to do data privacy sharing within and across Africa, where most of these data privacy protection laws don't even exist. And obviously the funding, which we don't have time to talk about funding, it doesn't exist. We have to figure out how to do this. So we have to overcome all of these barriers, which I talked about earlier, to figure out how to train experts, optimize infrastructure to give us really good imaging, even how we analyze, how we apply computational models to it, because we may have to build low cost solutions. And we have to figure out how to create networks so we can get data, validate the AI methods, and then apply them. And that's what we did with our funding. We created this African Neuroimaging Archive. I don't have time to go over this, but with this, we were able to start to overcome all of this infrastructure, policy, and personnel challenges. So at AFNIA, we were able to create, and this is again from the Lacuna Fund, this My Lab, Medical Artificial Intelligence Lab in Lagos, Nigeria. This is in the private center. This is a Treasury Radiology. And this is thanks to the visionary of Dr. Fatah Day, who actually gave us his clinic and gave us a space where we can actually do training. There is a seminar room down the hallway that sits about 60 people. There is a server right behind this wall where we can actually put and grow computers, which we're actually in the process of doing. And from this space, we've been able to really run the Spark, the Sprint AI training for African Medical Imaging Knowledge Translation Academy. And I'll talk about this a little bit. And we've done this over the past 3 years. This is a hub, and we've connected many different clinics, as well as research, or will I say, people that are interested in medical imaging, its application in AI. We've been able to do the summer school from there. With this, we've also been able to create the brain tumor segmentation data sets that includes Africa. This is the BRATS Africa data set. We've gotten a few awards from doing this particular project. So I'm going to just kind of walk you through how one well thought out framework, or AFIA framework, has been actually able to allow us to unlock the potential of AI in Africa, especially by bridging the gap through capacity building. So we've been able to essentially start to optimize the way we scan. So we've been able to do training, and I'm not going to be able to have time to talk about all the training, but we've been able to train IT physicists, radiologists. We've been able to start to train people on actually how to use the infrastructure and optimize it. We've started to build a high performance computing mini cluster, what I call it. Yes, let's just call it mini cluster. And with the emphasis on making sure that these produce optimized, say cost-effective, not low-cost, cost-effective AI models. And obviously the summer school, or the Spark AI training program, which I'm going to talk about in a second, that's training experts across all of the different disciplines that are impacted by medical imaging impact or intersects with. So when we train with a use case. So that way we can train everybody that's involved in that. So for example, we've been doing the use case for brain tumor segmentation. And so we train oncologists as well as neuroradiologists, as well as neurosurgeons, along with computer scientists, imaging physicists, and stuff like that. And then we've been able to form collaborative networks to allow us to collect rich data sets across Africa. We've done that with the brain tumor data sets. We actually are doing that, and this is what we're talking about closely before we logged on. This is our breast ultrasound data set. It's also funded by Lacuna, second round, and we're going to make this data set publicly available as well. For time's sake, I'm not sure if we have less than a minute to switch over.
Yeah, I think
we will switch over now.
Yeah. So for people, we will switch over. You'll get onto the same Zoom link, and Ling she'll be able to let us all back in. So sorry about that small little glitch. And saying you can continue until it kicks us out, I guess.
Sure. Now let me just. Let me find my pointer. I can't find my pointer. Can I find my pointer? Still not taking. Okay, just give me 1 second. I'm just going to stop sharing and be sure to find my pointer. That's probably the best way to do. Okay. Right. I think that should do it. Can I find? Oh yes, there it is down here. Perfect. Okay. All right, so just to connect back, so we've been able to use one program to sort of solve these 3 key barriers, or to start to work towards solving these 3 key barriers that I think that if we're able to overcome it, we'll start to bridge that gap. So I'm going to just talk about this brain tumor segmentation data set and its impact it's had so far. Because remember, with these data sets, we're able to pull people together within this clinic, from this clinic, I should say, use this data set to train people on how to annotate, so prepare the data sets, train people on how to even acquire the data sets, which you're doing right now, and train people on how to now use that data set to build AI models. So I'm going to talk about the impact of this data set. So over the past 3 years, we just wrapped up the third iteration of the BRATS Africa Challenge. This is a challenge that's run through the Medical Image Computer and Computer Intervention Society, the MICAI Society. It's running for 3 years now. We've had close to 400 submissions, about more than 50 teams around the world participating. Quite a few of them came from Africa, and I will tell you how we're able to do that, because this is not common. This is actually a challenge. It's one of the few challenges, or the only challenge, I think, to my knowledge, that's been able to get African participants to actually participate in medical imaging challenges, especially within an international society. This data set is available for anybody that wants to download the data set. Is in the National Institute of Health, so the NIH Cancer Archive, Imaging Archive, because this is the best way to find the data, especially if people are trying to build models using other data sets that are generalizable to make solutions that are going to come into clinic. So we want to put it where people can find it. It's highly findable. This is the most downloaded data in 2024 in this entire Cancer Imaging Archive. So if people want African data sets, and the data descriptor, if you want to know more about this data set, it's actually been published. So you can actually go ahead and find it there. One thing I want to stress is that we're actually using this data set now to actually train a lot of different people, even those that are not able to just come in and learn. So you can learn on your own. So we created this, and this was actually done by Ayomide. We created this lightweight, because again, we're trying to optimize our infrastructure, this lightweight deep learning brain tumor segmentation tutorial. And this tutorial is just based on a 3D unit that's been essentially set up to run on a CPU, because the idea is that we obviously don't have a lot of this GPU infrastructure in Africa. So this tutorial takes you through how to get the BRATS Africa data sets, how to use a 3D unit model, run it on your computer that's been essentially optimized to run on CPUs, and be able to get results that look like this. So if you go through this tutorial and you're not new to medical imaging, and you have some knowledge, or you don't have any knowledge, this is set up so that people can actually start to learn and practice and get skills all the way to even deployment. So we kind of set it up that way so that anybody can start to learn, no matter what their imaging or their computer science skill set is. I didn't have time to put the QR code here, but I'm going to show you this QR code, because this is where you can get it if you've missed the protocol.io page. And the reason I'm showing you this is because we've actually put this into practice. We were able to run this tutorial at the past radiology conference in Nigeria. This is the Association of Radiologists in Nigeria, one of the largest radiology conference actually in Africa. And so we've been able to do that there, and we do this kind of training. So in Daba, in Lagos next year, we're happy to do different types of this type of workshops there. I want to talk a bit about the training of the experts, because again, that's one key barrier that we need to overcome to bridge the AI divide. This is the Spark AI training program I mentioned earlier. This program actually takes a systematic way of introducing people to the how to develop AI models, how to implement and apply it to within the medical imaging space. So we have this very methodological process where we use, which is a 3-phase process, this teach, try, use, which is something we borrowed from radiology, from RAD AI, so Radiology Without Borders. And essentially what we do is we get people to learn the fundamental basics of a particular use case. In this case, this is teaching them how to build deep learning methods for brain tumor segmentation. So we start off by teaching them everything they need to know about deep learning, how to code, up to what medical imaging is, especially with application to brain tumors, teach them about the clinical aspect of brain tumors so they could understand the problem and build health-informed models, especially within the African setting, what brain tumors look like, the clinical features. Then we get them to try it out. So we run a hackathon. This is a brain hack. We run it every year across Africa. We essentially get them to try it out. So we give them some data sets, give them some past models, get them to propose models, play around with the data, and then we get them to actually use that knowledge that they've learned. So they've learned the fundamental knowledge. They've had time to try out and learn how to code and actually practice. And then we get them to use that knowledge, because that's how you impact and solidify that knowledge. So we get them to actually be part of the brain tumor segmentation challenge. So when you go through this process, you come out as an expert. And we've been able to cycle our trainers back into the program to essentially increase the number of participants. This is our first iteration of the BRATS hackathon across Africa. And this is again in 2024. This is different African centers. We're now also in Southeast Asia. This is Nepalese team. This is also in 2025. And if you want to learn more, you just have to go into Twitter or into LinkedIn, type in Africa Brain Hack. You see stuff going back to 2024. Here are some of the participants during the hackathon. If you want to learn more about Spark, essentially you can follow us on LinkedIn. William, one of the participants from 2025, and I'm going to talk a little bit about William's project. He essentially actually a few days ago gave a presentation at the South African conference on his deep learning method that he developed for brain tumor segmentation with that data set. So over the past few years, we've trained quite a bit of people. We're now reaching almost 700 people together over the past 3 years. We're across multiple different African settings. This is the main conference that we're linked to, that Medical Image Computing Computer Assisted Intervention Conference, where we run our BRATS Africa Challenge. That's a team that went in 23, 24. This is us in 25. The conference just wrapped up in September, so that's almost a month ago. We also publish quite a lot of these methods in the conference paper. This is in Lectures and Computer Notes, the LNCS. And this is one of the first models that were published in 2022. This is from 2023 program. It's a very good example because it's a segment anything model. This is a foundational model that one of the teams essentially tweaked, augmented, modified it, and you can see that their method, the Samba augmented method, performs better than the foundational model. So if you want to learn more, the papers are here. So we publish all the models that have been validated and benchmarked. And any of the models that come out of the program are all on a GitHub page. So if you want to go and try out, look at them, play around with them, that's also there. All of the winning models, so the models that have been ranked and benchmarked, which we've been collecting these awards over the past 2 years, from our training programs, all of those benchmarked high top performing models are also in a GitHub page. And another exciting thing to show this again, how we're now bridging that gap and bringing it to clinic, is this orchestrator. Now, this orchestrator is something that that's kind of moving towards getting these deep learning methods into the clinical space, since they've been benchmarked. And so if you want, again, to start to play around with the top performing models, it's actually now easier for you to do as opposed to reading papers and trying to figure out or getting the code. Everything has been sort of put into this BRATS orchestra, and all the winning models, their papers and all that stuff is there for you to be able to use. And if you don't know how, this archive paper actually describes it very well. Again, next we're going to run this challenge with a little bit of twist to it, so stay tuned for those that are interested in participating. We're also going to run the summer school again, the Spark Summer School next year. We've also run quite a bit of workshops at conferences. This is one way for us building this collaborative network, not just with participants or our colleagues within Africa. We're trying to now reach out to the global South, as well as connecting ourselves to the global North. So we can have this collaborative work of building really good models that are generalizable, but also include us. And for us to develop these models ourselves and make sure that our models also reach out to the West. So we have a lot of this collaborative network workshops that we tend to do in international meetings. You can see the footprint of our papers. We have people from all over the world, especially from the low-middle income countries coming for this. We have a proceedings paper. Our proceedings paper is going to come out next year. So we will run this again in 2026 when the conference goes to Dubai. Stay tuned. This is our participants from the conference that just wrapped up, the workshop that just wrapped up in September. I also wanted to point you to our monthly webinar series. This is a webinar series that's organized with multiple different labs in the global South, Nepal, Uganda, and myself with colleagues from University of Washington and our lab in Lagos. And we bring really top, established, well-known, world-renowned computer scientists and people that work within the medical imaging space to give lectures. Also, this includes clinicians as well. So stay tuned. This lecture happens every month. If you follow our My Lab Twitter or LinkedIn page, you'll be able to stay connected. One thing I wanted to point out before we start to wrap up is the AI imaging capacity. One thing we obviously have to do is to have the infrastructure, the computers. And so we're going to be making an announcement, hopefully within the next month or so, about this new venture that we're going to try to undertake. And one thing we're trying to do is to bridge that data center, not that we have a data center, maybe very soon, but to start to give the infrastructure, opening up that infrastructure barrier. So we have quite a few high performance computers coming into the lab. And we're going to create this space where people can bring a project, bring data, we'll give you mentorship, and we'll be able to give you access within a very good period of time to be able to develop and pilot a model and then be able to actually start to figure out how to now scale it up. So we're going to have this neuron infrastructure, and calls are going to come out later on in November. So if you're interested, you'll be able to start to use some of these applications. Now, just to sort of wrap up, I've talked about a lot of these training infrastructure based, training programs based on teaching people how to build AI models, but we have to go back and make sure that we're actually teaching them how to acquire really good data, because if you have bad data, you have junk AI models and you have junk performance. We also train them on how to really understand how to interpret these images, especially within, within the way our patients tend to present. And also we train them on how to maintain and sustain their imaging infrastructure, because oftentimes one key barrier is that the scanners themselves don't work or are not working anymore. So we have all these training programs that are essentially linked to multiple different international societies. And with that, we've been able to develop scan protocols. We have, obviously, I've talked about some of the AI models that are coming out of a program that are focused, done, built by Africans for Africans. We obviously have a lot of conferences linked to medical imaging, especially neuroimaging, that we are also analysis and interpretation. This is with focus on dementia. And again, our International MRI Society, we're essentially linked with that. And we have a lab book that's coming out on how to build a low cost, or like say open source, low cost, low field MRI scanner, which is a way to teach people on how to maintain that. So over a few years, we've done quite a bit in terms of connecting the African ecosystem of medical imaging, from the people that scan, radiographers, to the clinicians that read it, the radiologists, to the physicists that are sometimes not in medical imaging, they're getting them interest in medical imaging, to the computer scientists. And we're now building this really nice map of a network where we can actually be able to get data, share models, validate models, and start to bridge that gap. So how can we work together on this? I think one way to work together is to share and co-develop local AI solutions. If you build a model, share it, put it out there, let other people use it, validate it, apply it. Join our network, help us train people, come and learn also how to use your computer skills and apply it to medical imaging. Join a collaborative network, so that's how we can share data. That's how we can get also our international partners to work with us through workshops and conferences. And lastly, I want to end with this. Like I said earlier, we have now started to embed this AI knowledge into clinical spaces. A lot of clinicians are very hesitant, especially African clinicians are very hesitant to learn AI because they think it replaces them. So we have to have a way of bridging that gap by also getting them to be comfortable with AI. So they have to know what it is, to not be afraid of it. So we're starting to do this HANA conference, HANA workshops in AI conferences. We've done a bit in the Ugandan Radiology Conference, the Nigerian Radiology Conference, the Pan-Africa Radiology Conference as well. And we want to actually start to move the other way, bring clinicians to Indaba, for example, to where the computer scientists are. So we're super excited that the 2026 one will be in Lagos, which is not too far, hopefully. I don't know where the venue is, but if it's in Lagos, there's only a few places where it could be in Lagos where people can come in. And I think lab is really uniquely positioned to be, your lab in Lagos is uniquely positioned to be that lab that could bring clinicians to Indaba so that we can actually start to grow a community and also be able to bridge that gap. So I'm going to stop here. I hope we have time for questions. I want to thank the camera team, because a lot of these projects are done through the camera network, as well as the MyLab team and my students that allow me to do multiple different things, wear multiple different hats, and are always there to support me. So I'm super happy for all of the people I'm working with, and I'll turn it over to you for questions.
Okay. Thanks so much, Udunna. I think this is awesome, and it's especially, I think, on the part of highlighting how your system, the systemic steps that it takes to go from almost the pilot and then saying, hey, how do we scale more? How do we scale more? And you keep on iterating on that piece. I think the parts Lacuna Fund has been able to support. We're very okay, I'm personally, as part of what was used to be the steering committee member, very proud that this is some of the things that the funding was able to enable. We will come back hopefully soon with future plans of what's going to happen with some of the ways we're going to provide more access to funding for the whole continent in different areas. Health having being one of the big ones there. I wondered, especially for me, from my perspective, and maybe talking to some of the audience that is here, can you maybe give us some reflections, maybe that are more personal, especially about dealing with the people part of this? I think you've given us the technical iterations, but what does it take here?
Oh.
What does it really take to get these pilots out? I know people never talk about
part.
These things.
Yeah, the people part, that's actually a good question, a very great question, because I mean, I'm based in Canada. My day job is not this at all. And this is a passion project. And so the people part is two things. I think the most important thing is trust. Is to find people that you trust, especially within Africa where we are. And I'm going to be quite transparent. And also, I think if we're honest with ourselves, we'll be able to get some of this stuff done. We have a low trust society in Africa compared to here in Canada or in the West. We have a low trust society in Africa. So once you penetrate and build that trust, people now open up, especially when you're coming into to do something as highly advanced as, I would say, foreign. Because again, we're trying to apply this into clinical space. And there's this foreign thing about the clinical space. They don't know what AI is. And the people that do AI, typically the computer scientists that have some idea of what they're doing and have no idea of what medical imaging is. So you have this big bridge that we have to bridge. And you have this trust that has to go both ways. I'll give you one example. Most of the medical imaging devices, actually, there's only one center in Africa that has medical imaging devices that are dedicated purely to research, and that's in Cape Town. That's it for the entire continent. In Montreal, where I work, we have a 7 Tesla MRI, 3 different PET scanners, multiple different types of devices just for research. And that's very common in the West. So a lot of the data sets that we can share sometimes comes from these research scanners that are from funded. In Africa, I have to figure out how to do that. One thing you have to do is you have to go to clinics and encourage them that you need their data, that you can be a good steward of the data with them. And that trust has to go this way. And sometimes it doesn't happen very well. And that's the biggest issue, right? And I think when they see knowledge Africans that know what they're doing and understand what they're doing, that trust starts to build, for lack of a better word. And so we have to train people that are highly skilled on what medical imaging problems are. Because once people understand what the problem is and they see the vision on how to solve it, they will jump on the bandwagon and help you do it. So I think that's trust. And trust also means that we have to also figure out how to navigate a typical African, how do I put this politely, corruption. Okay. That is one big key. So I think trust, and that's why networks are very key, because we don't have, I can type in here and say, find me, ChatGPT, find me a medical imaging AI lab in Africa. I mean, now we'll find you one, it's our lab. But before we wouldn't. So we're going to find the clinicians, we're going to find the people, we have to figure out this network. So that's why networks are key. Once you build a network, people are willing to join, the trust builds. I don't know if that makes sense. And that applies to everything. Yeah. Applies to everything healthcare, not just AI, but everything healthcare. That's kind of my experience been. I don't know if that makes sense.
Yeah, no, it does. And I think I will open up for questions. You can raise your hand and it will just acknowledge you, and then you can either unmute and ask your question, or you can type in your question in the chat and I will read it out. But I think in this series that we've been running on data science and society now, I think for the last 6 years, it's across. It's not just health, it's just the health. I think it's because, again, you're dealing with people and these outcomes are very personal. Yes, there's an extra layer there, but then across everything, whether you're working on public transportation, you're working on energy, it's exactly the same thing. How you build trust and you understand people and how they work and what they've been trying to do in those areas. it's a very important thing. And I think for data scientists, who I take everybody who's on this call actually as, is to on some time spend time with the people who are the experts on the ground, because that's when they also understand that you're here for the problem, right? Not you're just here to collect the data and go do your work and
Yes.
and you disappear. So
Yes.
we tend to be, I think in research, it is something that people should understand, that some of the
Yeah.
hesitation is warranted, because that is unfortunately that the things that people in research or in academia are rewarded for are not necessarily going the whole way. It's just
Right.
showing some sort of, hey, I
Yeah.
can use this kind of approach. It works. I've written my paper. Now I move on to the next thing. But people were hoping
Yeah.
actually you were going to help them navigate very, very tough problems of society.
Right. And one other thing I'll say before we move on to the next point or question is that health research in Africa is a luxury. That I didn't say that. A African clinician told me that. An African radiologist told me that. Because for them, unlike us here in Canada or in the West, we don't have enough clinicians to even do the everyday job. Now we're going to add research, which paper publishing doesn't mean much to them, right? Especially in the private practice, there's no incentive for them to publish papers. And so we have to go beyond paper publishing. We have to go beyond building models just for science sake and moving into society's sake. And again, I'm going to stress this network issue again, because most of you attend Indaba or AI conferences that, like you said, cut across different sectors. The clinicians are not going to attend that.
Yeah.
That you have to come to them. And so I have to figure out the way to bring ourselves to them or bring them to us. And this is why this Indaba coming up in Lagos, we're going to try to pilot this. And I'm hoping that Indaba work with us with that. So we can bring clinicians into something that's called Indaba that they've never heard about. Because that's where you're going to meet them, sit down and talk to them and build that trust and start to do collaboration with them. So I'm just wanting to emphasize that, because that's really the key in trying to do everything. If you build trust, you can now go in and start to optimize the infrastructure. If you build trust, you can actually tell them to send your residents. You want to train them on how to do AI, right? So that's kind of how we got a lot of this stuff done.
Sure. I think there was a question earlier just on the tutorial, if you had a link for that so that we can put it in the chat. And then,
yes.
While you do that, yes, there was a question, are the GitHub files available to use freely? Lacuna Fund is just for context for people. I was on the steering committee all the way from inception. We actually worked on the pre-project to actually form the Lacuna Fund. It was called something else before, up until we unfortunately closed. But on that, the Lacuna Fund datasets, in most cases, under CC BY, or other permissible license that would have been negotiated. So you can get access to that data and you can get it as well. So just check on the, I did put the link to the pages where you will find the Brett's dataset as well. Question is the Spark Academy accessible to everybody everywhere? Because last year I tried to join the hackathon, but it was just open to people in specific countries.
Okay, so I'm sorry. I'm just yes. Spark is open to everybody that want to learn. Our only requirement is motivation. Because of how we structure the training, we have radiology residents that have never, some of them thought Python is a snake before joining. So we train anybody that is willing to learn. That is our motivation, especially people that are within Africa and now in Southeast Asia. So it is open. The hackathons are hybrid. This is a hybrid program. It's not a purely virtual program or purely in person. So during the hackathon phase, so we start off in a workshop. Workshop is purely virtual. So everything was done virtual. I'm actually trained people as a team. I didn't have time to talk about this, but yes, you come in as a team. You register, you apply. If you're accepted, you actually enter into a team, and your team stays with you all the way to the challenge, because that's how you build a network and you start to connect. So when you come in, this is all done self-paced virtually, anywhere you are in Africa or in Southeast Asia. And then we have the hackathon. Hackathon is a place for you to actually see people that live within you, that you guys have been talking and working together virtually or in person. And so we try to connect people as much as we can. Sometimes we have funding. If we have enough funding, for the whole week, we have a space. They go in, they do the hackathon from that space. If we don't have funding on that particular country or the location doesn't have enough space, we don't tell people to, here's a little bit of money or whatever, just go and co-mingle, find a coffee center for you guys to just say hello. So that you can do this without being in a specific country. We have people that have participated, being the only participant from the country as well, participating purely virtually. So yes, it's going to open up next year. We have people like Ismaila Lukman here with us, who is one of our seasoned Spark trainers. So yes, you can join in, and I think the number is going to grow next year. We want to cover all of Africa next year. So yes, please apply. We want to see you. We want to have you.
Okay, some questions for people who might be alumni of the Sprint program. Where can they get more opportunities for work in these spaces? I know this is always a tough one.
That is a fantastic question.
We also face that in general with the Indaba, especially at the beginning, because it was this thing, everybody now gets very excited. They want to do more. And now what are the, local opportunities might not be as much there, but then how can they think of this?
Yes. So for us, I'm going to talk and swipe back, because I think visualizing something makes more sense. Yes, we're trying to put together Spark Next, which is a program we're going to hopefully kick off next year, early next year. And this is all thanks to Raymond, who I don't know if he's here, a PhD student in my lab, that's been running Spark fantastically since the beginning. So we're going to build this program called Spark Next. It's a transition towards entrepreneurship, bringing entrepreneurship, because that's one of the missing pieces. So this will be teach, try, use, and an entrepreneur, like go ahead and start to go ye and prosper type of thing. And we are hoping that we'll be able to give people some of the resources that they need to venture into this space. Because if you're doing anything AI in healthcare, radiology is the place to be. So build the softwares. We need them. We need them to be our own softwares. We don't have to go through FDA to use them in Africa. We could make sure we set up our own way of validating this AI software. That's a big gap. It's just a lot of things that young people can do. Set up your own space. And so one way of doing that is to coming in and working with clinicians. There's lots of clinicians that want AI to help them, not replace them. And there's so many different projects that are out there that people are doing. I think Ismail is one of them. He's building this Afro-biobank. He's a student, he's a postdoc right now, and he's doing that. So I think there are multiple ways of entering into this space and being profitable, if that's the right word. Entering into this space and being able to sustain yourself and keep yourself in Africa and employed. And so we're trying to create that Spark Next program to bring in people that have built softwares, people that work in industry, to start to give you ideas on how to do that. And that should be hopefully coming out next year. So stay tuned for that. I think that could be something that, because we can think about this in Daba next entrepreneurship collaboration. I'm happy to also, touch bases with you on that as well. You're muted. Because you're muted. I was going to read your lips. I can't read lips.
We have like 2 minutes left or so. As we close, Chris will come on, but there's a lot of opportunities in the chat that people have been putting up, and links. If we are not yet on our newsletter, please do so. We will expand. As we said, this year was our year of AI and health, and we've kept to that. And hopefully you feel that we've kept that promise to everybody. Chris, you ask your next question, and then I will come up to you, Yusupa, as the last question to Udunna. Yes, Chris.
Sure. Thank you for Kosi, and hey, everyone. Udunna, thank you so much. This has been such a great talk today. So much of what you've said has really resonated with me. I have been plugging a new initiative in the chat, and I just love when you say you're talking about trust, you're talking about entrepreneurship. So this initiative looks to drive that forward. I've been working in data accessibility for the Western Cape government for the last 2 years. And accessibility has been top of mind for me. So this initiative looks at building African open business models around democratic business, so cooperatives, and sort of builds on the platform cooperative movements. And if there's anyone who's interested in looking at that as a socially aligned entrepreneurial way to make sensitive data accessible in Africa, please do hit me up. And thanks again for the talk.
Thank you, Chris. I'm just trying to find you where it is, but let me just see. And, oh yeah, this is fantastic. Thank you, Lukman. I mean, I was a little bit peeved when I saw this, but anyways, we'll talk about that later. So I think, Chris, you're referring to, I'm just trying to find, oh, this, yes. For those that haven't seen it. This is fantastic. Thank you, Chris.
Yes. And just to note, myself and Lukman are already working to use the AfriBiobank project as a pilot project. So that's already moving forward.
Yeah,
Okay.
I actually will connect with Ismail about that. I want to talk to him about that, but I'll connect later on with you guys. Fantastic.
Okay, the last question, Yusufa, was what's your advice in some under-resourced countries where medical images are still printed on film with no digital copies? And then how does this connect with people who might be interested in AI and medical imaging?
Yes, so we have the AFNIA, the African Neuroimaging Archive is a fantastic way to do that. The Brats Africa started with also films, or some of them, they were on CDs. If they're DICOM, we can take them, we can save them. We have ways of doing that. So we're going to have a call again for AFNIA coming out later on. So keep an eye on that. That's one way. Another way is that we're building this low-cost, open source-ish picture archiving system called Hasky. The information is on our website, the MyLab website. This is a way for people to essentially have their own packs at their hospital and be able to, a medical imaging center, and be able to store and save images. So two ways is contribute what you have to AFNIA. We'll teach you how to use it, how to store it, how to also access other people's stuff. So federating data. So data federation is one way. And second way is we are building actual resources for you to be able to start to store and save your own images.
Okay. All right.
I have a hard stop. So
yeah, on that, thank you so much, Udunna, for coming through, and thanks everybody for joining this series this year. Yeah. All right.
Just before we go, I just wanted to say I did post it in the chat, but Sisonke Bartek, we are having a workshop at Science Forum South Africa on November 25th.
Okay.
We are planning to have two more seminars in the build-up because there's about a month for that, and anybody who wants to come is welcome. The registration is free, and also there's a link there to register for Science Forum, which is also free. Thanks for Kosi.
Okay, thank you. Sorry, Lang. I almost forgot you because you just named host. Okay, thank you, everybody, and enjoy the rest of your Friday. Bye.